We're going to go ahead and get started this morning. I am very pleased to introduce Dr. Charles Grob, who's going to be our speaker today, talking about psychedelics and psychiatry. Dr. Grob is the director of the Child and Adolescent Division at UCLA Harbor, and he is a world-renowned researcher in the area of psychedelics and mental health. He's published over 100 peer-reviewed articles in the area and has really dedicated his life to furthering our understanding of this field. So I'm very pleased that he's agreed to join us today to give us an update in this area. So without any further delay, please welcome Dr. Charles Grob.
Okay, thank you, and happy to be here today to talk with you about an area I think of increasing interest to the culture at large. It's a topic I've been interested in since the beginning of my medical education, and I think now with recent developments, I think interest is sparking up. So I've over the last few years, I've given a couple of talks at grand rounds describing different studies I've been involved with. I'll present a little bit of that here, but also try to get to some kind of new material and a sense of, kind of an update as to new directions and new potentials perhaps being realized. So psychedelics and psychiatry, a new treatment model for the 21st century. Well, that remains to be seen, but I'll try to give you a little sense of what's going on and what the basis for that might be. So financial relationships, I've done research in a few different areas involving psychedelics. I did the first phase 1 study with MDMA, and more recently an MDMA treatment of social anxiety in autistic adults, which I'll present kind of a little bit of our data there. That was funded by an organization called MAPS, the Multidisciplinary Association for Psychedelic Studies. I've also done research in Brazil, starting in the Brazilian Amazon with a syncretic church called the UDV. That was funded in part by the Hefter Research Institute. And the Hefter Institute also funded the pilot study I did using a psilocybin treatment model with patients with advanced cancer anxiety, targeting the anxiety, not the cancer per se. I should also mention as disclosure, I'm a founding board member for the Hefter Research Institute. Now, NIMH is on my list simply because we use the General Research Center. They funded. NIMH has not funded a clinical psychedelic study since the 60s. Hopefully that will change in the not too distant future. And the Betsy Gordon Foundation, we were running some of our early studies on a shoestring, and when we ran out of money, Betsy Gordon came to our rescue, so we have to include her as well. So, so we know that there's a real problem in that whereas costs for mental disorders treatment is increasing or has maintained some consistency. Let's see what comes out here. There's been a consistency in terms of the degree of the population with severe mental illness. Costs have kind of skyrocketed. The rates of various disturbances, suicide rate, also particular drug addiction rates have also climbed. So there may be a sense that we need something else, that the conventional paradigms which have been in place since the transition from the old psychoanalytic paradigm to the psychobiologic paradigm, let's say in the 70s, there's been a kind of a static state since then, and I think some may suggest that drug development has kind of run out of new models and new paradigms. So the question then is, do we have something here? Are we ready for a paradigm shift? Thomas Kuhn, the philosopher of science, described paradigm shift as a radical change in underlying beliefs or theory, and kind of to be replaced by something new and novel and hopefully more effective. Are we at that point where we're anticipating a shift in in paradigm, in treatment model? So with psychedelics, you know, well, first of all, what do we call them? You know, the term psychedelic translates from Greek as mind revealing or mind manifesting. It was coined in a famous exchange of poems between Aldous Huxley, the famous British writer, and Humphrey Osmond. Huxley wrote to Osmond was a Canadian psychiatrist researching mescaline and LSD in the 50s, treating alcoholics with actually quite good effect. Huxley wrote to Osmond, to make this trivial world sublime, take half a gram of phenerethyme. Osmond wasn't quite satisfied with phenerethyme, so he wrote back to fathom hell or soar angelic, take a pinch of psychedelics. So that's how the term psychedelic came into play. It was also the term widely ascribed to these drugs during the heyday of the tumultuous 60s. And some have thought there may be some alternative term which is preferable. Entheogen, which references the divine within, has been popular in some quarters, first coined by Houston Smith, a Harvard doctor of divinity, professor of divinity there. But not all psychedelics evoke this experience. And then hallucinogen, which has gotten kind of a bad rep in many respects for over-pathologizing these compounds. Really, if you look at the Latin root is hallucinare, or mind wandering, mind traveling, tripping, as you were. So perhaps a better term there. And then there's some alternative terms. I'll just point out my favorite is fantasticant, although that was Louis Lewin's word in the 20s, a famous German pharmacologist, but that never really gained traction. So the classic hallucinogens they're structurally, they're very similar to 5-hydroxytryptamine or serotonin. Psilocin, the active metabolite of psilocybin is 4-hydroxy and then dimethyltryptamine, and LSD also with this indole ring. You see the similarities there. These psilocin or psilocybin and LSD are considered, along with mescaline, are considered the classic hallucinogens. DOI is an interesting compound in that it may have some potential in the medical world at psychoactively subthreshold dosages. It appears to have profound anti-inflammatory effects. Charles Nichols at Louisiana State University has written some interesting material on that. Also, not well known, but the discovery of the serotonergic system attributed to work using LSD in the laboratory. Some of that by Daniel X. Friedman, former chair at the University of Chicago, and later professor emeritus here at UCLA. We know that the 5-HT2A receptor is primarily at play here. These are agonists of that receptor, and an antagonist for 5-HT2A cantancerin has been shown to block the psychoactive effects. Also, repeated administration causes tolerance, and there's actually cross-tolerance among the different classic hallucinogens. These are some of the non-classic ones. N-bomb is now found to be a substitute on blotter paper in microscopic amounts for LSD. There have been some overheating deaths attributed to N-bomb. Salvinorin A, the active diterpene from salvia, is a very bizarre experience. I haven't heard anyone tell me they've taken it more than once, to give you an idea. It's oddity. Ketamine, obviously, in the last couple of years, widely popular. It's never been Schedule 1. It's a Schedule 3. It's now being used to treat depression, among other conditions. This is not a talk on ketamine, but I have some reservations about that model. Ibogaine has been used to interrupt addiction. It also has severe cardiovascular problems, so it's used with care, and it's only been researched to a modest degree, although there are offshore or out-of-the-country clinics where Ibogaine is applied to mostly opioid abusers. And although there's reports of good outcomes, it's never been rigorously or methodologically studied. And then MDMA, aka ecstasy, or Molly, is a substance my group has studied, and I'll be talking a little bit about our research and some other research, because that's one of the new developments in the field. It's not so much a psychedelic as perhaps an empathogen or an entactogen. It has a unique array of effects. So hallucinogens originally occurred in nature. Most of what we know about with synthetic hallucinogens were derived from isolated alkaloids and diterpenes from natural products. So here's psilocybe cubensis, from which psilocybin comes. Lopha-4-Williamsi is peyote, and mescaline is the active alkaloid there. And curiously, a fungus that grows on rye, an ergot fungus, Claviceps purpura, is structurally very similar to LSD, and is suspected to have been part of the sacramental beverage used by the ancient Greeks at Eleusis, the kikikion. And so it may, although it was kept under great secrecy, there's pretty good evidence that Claviceps purpura was involved in the production of that beverage. Now there's ayahuasca. I've spent some time in Brazil. So it's not an ayahuasca talk, but I can't give a general talk without mentioning. Ayahuasca is a decoction of two different plants. If you ingest orally either of these plants by themselves, nothing happens. Psychotria contains DMT. Banisteriopsis contains harmala alkaloids. The DMT in Psychotria is generally rapidly metabolized and degraded by the monoamine oxidase system in the gut, but the harmala alkaloids in Banisteriopsis are monoamine oxidase inhibitors, so it allows for absorption and activation of the CNS to create through the ingestion of ayahuasca. And it's a kind of a preparation that's prepared over many, many hours, and a concentrated distillate is provided. But how the native peoples knew of this, as a reductionist scientist, I would say, well, over centuries, trial and error, sampling every plant in your area for its nutritional value, making sure you knew which ones were toxic, and are there any visionary plants? The native peoples may have learned to combine that Banisteriopsis augment in certain effects, and however, if you talk to the native peoples, they'll start referencing divine intervention and pointing the way that the two plants might work together. But I'll stick with my reductionistic theory for now. So we do know that plant hallucinogens have been used for millennia, going back thousands of years. Here's a drawing based on a cave painting in the southeastern Tassili Plain in Algeria, and you can see this is from 7,000 years ago, and you can see along his or her extremities and torso there are these mushroom outcroppings. The significance of the beehive mask was, without refrigeration, there needed to be a way to store these compounds, nutritional compounds or psychoactive compounds, and they found that honey was a good preservative. So this is a depiction of a shaman among an ancient people in modern-day Algeria. And we know that these compounds, the plant hallucinogens, were used for religious and medicinal purposes as part of initiation rites, diverse cultures around the world, and it may very well have profoundly influenced the evolution of religion, philosophy, and art. Range of effects of these compounds: they induce a sustained altered state of consciousness with alterations of perception, mood, and cognition in an otherwise clear sensorium. They're more visionary experiences as opposed to what we may imagine as visual hallucinations. Frank hallucinations rarely occur. It's more of a kind of an eyes closed thematic story that's played out in the user. Often with opportunity for insight with whatever issues the individual goes into the experience with. These compounds also cause synesthesia, where different perceptual modalities are fused together in odd ways, like seeing sound or smelling color, also ecstatic states, ego dissolution, experience or union with others and the natural world. These are similar to dreams and spontaneous epiphanies and to some degree psychotic states under certain circumstances in some individuals. There's a preservation of orientation, memory, and ego identity, and really important, set and setting. These are critical determinants for outcome. The set is the, who is that individual, what is his or her underlying vulnerabilities, what is their purpose for taking this compound at this particular time. Is it for kicks? Is it a recreational expectation? Then I think there's a greater likelihood of problems. Setting is where one takes it. Is one taking it in a quiet, aesthetically pleasing setting with someone monitoring the experience, making sure the individual stays safe and is contained and not left alone? Or is someone outside in an intense environment, walking around the city with crowding and noise and a lot of confusion making? That could be the setup for a very bad outcome. So you want to really, if one is embarking on exploring these compounds, really work on optimizing the mental set of the individual taking the compound and the environmental setting, where it's being done and who else is there. And there really should always be a guide or a monitor to make sure the individual stays safe. It's critical with these compounds to maintain safety, or whatever potential they may have to be of value will be disregarded if too many safety problems emerge. So it's not quite, I think in today's world, realize that in the 50s and 60s, these were considered in some quarters among the cutting edge of psychiatric research. And quite a number of different applications were tried. And these were some of the conditions. And you can see that many of these conditions are among the most difficult to treat disorders we have in psychiatry. Alcoholism may be still one of the more challenging areas to treat in modern medicine. Someone comes into your office today, he's an alcoholic, you refer him, the same as you might have 50, 60 years ago. You refer him to a 12-step group, and if it helps, great, but a lot of people don't resonate with a 12-step group. Early work, starting with Osmond, and then in Canada, and then Grob in Maryland, identified a quite impressive degree of response to even a one-session treatment within the context of a psychotherapy, of a psychedelic treatment model. Other conditions very difficult to treat: chronic PTSD, obsessive compulsive disorder, notoriously hard to treat, antisocial behavior. There was some early work with autism. It's difficult to know what was being done. These were with often very young children, very disturbed children. There's certainly some ethical issues, some consenting issues there, and also some diagnostic issues, because what we diagnose as autism today may not have been what was diagnosed years ago. Years ago, they were actually calling these children childhood schizophrenics. Reading the case reports, they appear to be more on the severe autism spectrum. But again, there are ethical, I think, restraints in that area. When we studied autistic adults, we were not treating the autism per se, and they were adults, I should point out, but we were treating the reactive social anxiety in basically a very challenging patient population. And then finally, an area that we spent a good deal of time, and some of the best research out of the 60s, was working with individuals at the end of life who are overwhelmed with existential kind of anxiety and demoralization, loss of meaning, loss of purpose to their lives. They were in true psychological and psychospiritual crisis. And Walter Pankey and Stanislav Grof, two of the pioneers in that area, had very impressive reports on patient outcomes, even with just one or perhaps two treatment sessions within a context of more or less a kind of a Rogerian psychotherapy. So Lester Grinspoon, a prominent Harvard psychiatrist, with his colleague Jim Bacalar, did a survey of the literature through the 50s and 60s, identified upwards to 1,000 papers published in the professional literature detailing the experiences of some 40,000 patients. And this is what was just published. Believe me, there was far more that went unpublished. So this was a this was an area that attracted a great deal of interest, and there was a lot of enthusiasm. But then, as we all know, the 60s erupted, or the late 60s, and there was just a lot of cultural and political turmoil. These compounds became identified with a politically active counterculture, and the next thing you knew, it was impossible to get new research permission. In fact, there was no new research permitted. There were some old projects that kind of meandered along on a very low level, but there were no new studies permitted from the late 60s until the early 90s, when our group and a couple of other groups, as I'll describe, got permission for a few phase 1 studies. So this is just publications with psilocybin, and it just points out that there was really a great deal of interest in the 60s. It almost flattened out by the early 90s and then picked up again in the 2000s. If we had an LSD slide, there'd be far more publications, but even a greater flattening out, because except for one study in Europe using it with terminally ill patients, there have been no clinical LSD studies, whereas there has been a significant uptick in use and interest of psilocybin. So the phase 1 studies, these are essentially to establish baseline safety parameters, explore physiological reactions, psychological reactions. The first one permitted was a DMT study, dimethyltryptamine, at the University of New Mexico, run by Rick Strassman. And this was an intravenous administered DMT. They used dosages up to 1.1 milligram per kilogram, which is way, honestly, too high. And Rick tells me that all of his volunteers said that was way over the top, and they would not want to take such a dose again. So again, we need to be cognizant of the limitations. We did the first phase 1 study at MDMA in the early mid-90s. FDA stipulated subjects had to have prior experience. This is because of the concerns at that time of the potential of neurotoxicity. That's been, I think, to a significant degree rebutted over the last 20 years. We don't hear much about neurotoxicity, but we were successful in completing our phase 1 study. Deborah Mash at the University of Miami did a phase 1 study, although her subjects were opiate and cocaine-dependent subjects, but still it was very low dosages to obtain some baseline data. She became frustrated with the slow rate of progress and basically pulled up shop at Miami and opened up a clinic on St. Kitts in the Caribbean, where well-off addicts would come and get treatment. Sadly, she did not publish any data, at least that I'm aware of. So that's kind of a lost opportunity. And then a couple of research groups I was involved with, first with Dennis McKenna and J.C. Callaway, and later with Marlene Dopkin de Rios. I went down to Brazil to do some field research of members of an ayahuasca church, the União de Vegetal, that has permission from the government to take ayahuasca as a ceremonial sacrament. Curiously, ayahuasca was the subject of a case in our federal court that I was the expert medical witness on in the early 2000s that actually won in federal court. The freedom of religion rights were upheld for this ayahuasca church located in Santa Fe, New Mexico. It was appealed all the way to the U.S. Supreme Court, where in 2006 it won unanimously by a very conservative court. So I guess freedom of religion rights trumped the drug war in that instance. And then in the early 2000s, I was asked to come back. In the initial permission or legal sanction was covering all ages. Now, by the early 2000s, there were some expressed concerns in some quarters that adolescents who would participate with their families at special family ceremonies might be harmed. So we did a very careful, controlled study of adolescents and found, overall very good medical health, very good psychological health, good cognitive function, And the only difference we found was that they were far less prone to experiment with alcohol and other substances of abuse compared to the matched controls who had never taken ayahuasca. So there, I think, some reassurance there with these kids. Now, more in the modern era, some very important work has been taking place at Johns Hopkins under the leadership of long-term researcher Roland Griffiths. And his first interest was examining the degree to which a hallucinogen, in this case psilocybin, could reliably invoke a powerful psychospiritual or mystical level experience. This was significant, not just in regards to exploring the range of effects of the drugs, but some of the researchers from the 60s found that the strongest predictor for positive therapeutic outcome was the experience during the course of what was often just one multi-hour psychedelic session, was having a mystical level experience. So the mystico-mimetic effects of these compounds have some significance, and what Griffiths and his colleagues were able to demonstrate was that under optimal conditions with properly pre-screened and prepared subjects, they were able to reliably induce these psychospiritual epiphanies, these mystical experiences, which were even a few years later were accorded by the subjects as being among the most powerful and meaningful experiences of their life. But in terms of treatment, if you know that that mystical experience is a predictor for therapeutic outcome, and you're able to reliably, under optimal conditions, facilitate a mystical level experience, it really, I think, augments the potential therapeutic value of such compounds. So psychedelic peak experience was a way some of these early researchers described the mystical experience, and this is essentially defined as a sense of oneness, a sense of unity, transcending time and space, a profound, deeply felt positive mood, a sense of awe and reverence, a sense of that psychological and philosophical insight had genuine meaning and significance, and then also ineffability, very difficult to actually articulate such experience, paradoxicality, things are not necessarily what they may initially appear to be, and transiency. You're in this timeless experience that seems to go on forever, and then it's over, and it's like it's gone in the, in the kind of the flash of an eye. So. So these would what make up a psychedelic peak experience, or I think today we'd call them mystical level experience. So phase 2 studies have been ongoing in the starting in the early 21st century. Phase 2 is a more or less with relatively modest numbers of subjects, establishing whether you could safely and effectively treat specific patient populations. So we were the first group in the early 2000s to use a psilocybin treatment model for anxiety in individuals with advanced stage cancer. My colleagues at NYU, led by Stephen Ross, were permitted to use a slightly higher dose by FDA, and they also work with advanced stage cancer anxiety. And then Roland Griffiths at Hopkins had permission for even a higher dose, but got frustrated rather with the slow rate of recruitment. So his study recruited individuals who were not necessarily approaching the end of life as our study, the NYU study, did, but he was able to more successfully complete the study. All of these studies were placebo-controlled. Our study and the NYU study used niacin as an active control. I'm not sure I'd recommend that today. My two most severe adverse reactions during a treatment session turned out to have been on individuals receiving niacin. So they tolerated psilocybin much better. So I'd lay off the niacin. And then at Hopkins, they came up with a different approach, which I kind of questioned, which was instead of using a different compound altogether. Their active placebo was simply low-dose psilocybin. And what we're learning with all the interest in the microdosing phenomena, that even in doses that we might assume to be sub-threshold psychoactively, maybe there's something going on that's not that evident, but nevertheless going on. So for our most recent MDMA study, I wanted to back off. I couldn't find an active placebo that I thought really worked effectively, so we simply used kind of cornstarch, entirely inactive. And that was the most, that was, I think, the easiest placebo to work with. And in all of these studies, the subjects functioned as their own control, meaning it was blinded, double-blinded, and randomized into either receiving the active drug first, or the experimental drug first, or a placebo, and then on the next session, which would be about a month later, it would be the other condition. So the treatments generally, we took a drab hospital room and we fixed it up. In its natural state, it's a whole lot worse than this. Some of the groups have very fancy rooms. We were scraping by on a minimal budget and work with what we could work with. But you do need to, after screening, people need to be provided at least several preparatory psychotherapy sessions. They need to understand what the terrain is that they might be embarking upon. And they need to, it's very important to establish a rapport and trust with the therapist. And there should be two therapists. I'm a believer in kind of a male-female dyadic team. For a variety of reasons. I can go into that later. There can be exceptions to that, but I think that's your default approach. Studies used, our study used a double-blind placebo-controlled crossover methodology. Niacin was our active placebo. We had a moderate dose of psilocybin. We were able to use our GCRC back in the days when we had a GCRC. And there was follow-up going on for 6 months for evaluation and for facilitation of integration. These are our subjects. There are 12 subjects. Curiously, 11 were women. 4 had breast cancer, 3 colon and colorectal cancer, and then 1 each peritoneal cancer. 2 ovarian cancer, and then 1 of multiple myeloma, salivary gland cancer, and peritoneal cancer. And none have survived. All passed within a couple of years of the treatment, as was expected. We published in the Archives of General Psychiatry. It's the #1 impact journal at that time. Now it's been renamed JAMA Psychiatry. I don't know that that's another entry in my CV. Probably not. The same paper? Probably not. So anyway, the Archives of General Psychiatry is fine. So, physiologically, very mild effects, just very slight elevation of heart rate, very slight elevation of the of blood pressure. You see diastolic. It moves up a little bit, but still quite low, nothing to be concerned about. Over the 2 weeks following treatment, there were no changes in mood ratings. However, looking at the 6-month data, you see an improvement in mood that was sustained over this time, reaching significant proportions at the 6-month point. So we were pleased to see that. Then we looked at the state trait anxiety inventory. No changes 2 weeks after or even 6 months after. This would be 6 months after the psilocybin session. And there's no placebo contrast because everybody ended up getting treated. But with the trait measure, the state trait measure, whereas there is no initial effect, we did find a sustained reduction in anxiety that did stay sustained over 6 months, and at a couple of points reached significance. So again, we were pleased to see that. Steve Ross's study at NYU. Here's some of his data, and again, you could see the active treatment, compared to a placebo treatment. He found some good results there. Roland Griffiths at Hopkins. Here you see that, curiously, whereas there is a significant drop in depression scores with the high dose, by the end of the second session and sustaining 6 months out, the low dose, so-called placebo group, also managed to record very low depression ratings. So that was curious as well. So at this point, there have been no other studies looking at treating a population of individuals with advanced cancer, except for one early study in Europe using LSD. But there is a hope that in the not-too-distant future, we'll be able to get this work back up off the ground. So other phase 2 studies going on around the country. Treatment of alcohol abuse disorder by Michael Bogenschutz, who was previously at the University of New Mexico, is now at NYU, has collected some very impressive data on remission of chronic alcohol use and being sustained over time, quite similar to the data obtained by Humphrey Osmond and Stan Grof in the 50s and 60s. Peter Hendricks at the University of Alabama is treating cocaine and crack addiction. Matt Johnson at Hopkins treating smoking cessation, which is an indication I never would have imagined could be amenable, and yet his data compared to standard treatments are very impressive. And in the UK, we have a treatment of depression study by Robin Carhart-Harris and colleagues. Looking at MDMA's use in PTSD, MAPS has funded quite a number of studies, all led by Michael Mithofer, and taking place in various locales. So for MDMA treatment of PTSD, all patients must have failed prior treatment. They've now treated over 100 patients and with very good results. You can see here the CAP score, 2 months. This is baseline. This is a measure of PTSD symptoms. And here we are 2 months after treatment, and it sustains or actually even improves almost 4 years after treatment. Some more data from Michael Mithofer, simply looking at the CAP scores with the actively treated group compared to a control group, again showing fairly vigorous response. And here's a paper my group at Harbor, UCLA, published last year. Alicia Danforth is my psychologist, and she's the lead author. She did most of the work, I must say, so she has to be rewarded. And we treated autistic adults with incapacitating social anxiety and got a very good response. Here we had a social anxiety scale. We had the good fortune of having the same rater for the entire study. Chris Struble was a psychiatric resident who actually continued to volunteer his time even after he graduated. So I was very appreciative for Chris's involvement. And you can see here those, again, not a large-scale study, but you can see significant results, even with modest numbers, with social anxiety reductions according to the Leibowitz Social Anxiety Scale in the treated group, whereas the placebo group, an initial improvement, perhaps from all the attention they were getting. You know, when someone getting a placebo is sitting with us for 6 hours, there's still some therapy going on. So there's an intensive therapy model, I guess, for them, but augmented in these cases with MDMA. The Cohen's D was 1.4, which was fairly impressive, we felt. So phase 3 studies are larger scale studies that are generally identified as preludes to perhaps establishing these treatments as having clinical indications out in the world. So there are 3 phase 3 studies that have been approved over the last year. One has started. The 2 are going to be starting soon. One is with through MAPS, the MDMA-assisted therapy for chronic PTSD. They're up and running in a variety of sites around the country. Then there are 2 kind of competing private entities that are using a psilocybin treatment model for refractory depression. Compass is based in the UK. They're trying to expand to the US. USONA is based in the US, trying to expand to the UK. they've just come on the scene each in the last few years, but they come in with a lot of funds. And given that there are no federal funding in this area, private funding can really take control of the direction of a field. They have all been, the MDMA treatment of PTSD and psilocybin treatment of refractory depression have been given breakthrough therapy status by FDA, and again, it's entirely private funded. So back to the paradigm shift. This is what we've been working with for years. I remember when Prozac hit the market, I guess in the late 80s, early 90s, there was great excitement. And I swear, Prozac was more effective back then than it is now, which I'm actually stealing the line of Sir William Osler, the English-Canadian famous physician turned the previous century, who once said that it's important to use a treatment soon after it reaches the market and before it loses its effectiveness. So, yeah. So here's conventional psychopharmacology, a drug administered on a daily basis for weeks, months, years. Presumably, it's impacting a pathologic brain state, and the alleviation of symptoms are not necessarily dependent on the patient's attitude or insight. Now, there's an alternative, and it's no longer the taboo model that existed for some decades. It's now gaining a greater degree of acceptance, and it's getting some serious consideration. So with psychedelic psychopharmacology, within the context of an ongoing psychotherapy, it may need to be administered on only one occasion, or perhaps a few occasions. Lower doses loosen defenses, facilitate insight. Higher doses may induce a mystical experience. These experiences must be very, very carefully monitored and conducted within the context of a supportive psychotherapy. Now, part of the change in this country over the past year, I think, is attributable to this book. Michael Pollan, who was a very, very well-known author, kind of a celebrity author, and he had a #1 New York Times bestseller last year, How to Change Your Mind, The New Science of Psychedelics, and it became wildly popular and perhaps giving it somewhat more credibility. I have somewhat mixed feelings about this book. I think there are some misleading aspects of the book, but it has also done a service in getting this issue out to the greater culture in an acceptable manner and allowing it to at least get more careful scrutiny. So what's next? Well, here's what's next. I did not anticipate this. As you know, a couple of weeks ago in the city of Denver, there was an initiative on the ballot that decriminalized mushrooms. And again, I was not expecting this. There was an effort to put it on the California ballot in 2017, but it didn't get enough signatures. I actually wrote an editorial at that time saying that maybe we're not at this point, that it could be a little more complicated. But the fact is, we got to deal with what's going on. And it was a very close vote. It was losing the entire day. And then at the very end of the day, the votes flipped, the tallies flipped, and it won. So what are going to be the implications of this? I'm not sure. My concern is there's going to be a lot of people who may not be proper candidates for taking this kind of compound. Taking it with minimal information under suboptimal conditions, possibly mixing with other drugs or alcohol, who could get into a great deal of difficulty. What I'm calling for is, and I think it's a responsibility of the people who put this initiative up on the ballot, as well as the Denver public health authorities, to roll out some kind of public education program so individuals know kind of how to structure these experiences in an optimally safe manner, and not just have it be a free-for-all out there. When marijuana was first legalized Colorado, Maureen Dowd, the New York Times columnist, went there. Somehow or other, she had never taken marijuana in her life, and she felt this was the occasion to try it. She went there, she bought a cookie in a store, she had dinner, she went to her hotel room, the instructions were eat a quarter of the cookie. She ate a quarter of the cookie and nothing happened. So she waited, nothing happened. She ate another quarter of the cookie, figuring they must have given her the wrong instructions. Nothing happened. Remember, she had a full stomach also, but she's getting a little hungry again. So she's nibbling and nibbling and nibbling. Before you know it, she devoured the entire cookie, and then it started to come on, and she had the worst night of her life. Now, translate this to someone with some mushrooms in a Denver hotel room, I'd be very concerned. So, again, I think it's responsibility for the good citizens and authorities of Denver to put some safety measures into place. But there's, as I said, there's growing interest in psychedelics. Now, of all groups to be interested in psychedelics and wanting to learn about psychedelics is the FDA. They organized they called a mini symposium in their Silver Spring campus in Maryland, outside of Washington, in late April. They invited me and Roland Griffiths and a few other colleagues from various institutions doing this research to basically help the FDA better understand the range of effects of psychedelics and how they could best regulate their use in research studies. So I was very impressed with the people from the FDA who had just a genuine motivation to learn and to do a better job. They also invited me to a meeting last week in Scottsdale, Arizona, the annual meeting of the American Society of Clinical Psychopharmacology. They asked me to be the discussant on a panel where they presented on psychedelics. And I thought I was quite impressed with how forward-thinking they were and how brave they are to kind of take this issue on in a positive way. And very cool poster by them. Maria Sabina is the Indian healer from Mexico, the curandera, who first gave R. Gordon Wasson, an amateur mycologist, explore samples of psilocybe cubensis at a time in the 50s when it was not believed such compounds existed. Albert Hoffman, the famous Swiss medicinal chemist who not only discovered LSD but also isolated psilocybin from mushrooms provided by Wasson and others, Claudia Naranjo, a Chilean researcher. So the FDA is now quite interested in psychedelic research and is being proactive in trying to do things right. So after some 50 years of it really being kind of suppressed and shuttled to the side, there's now some new opportunities. But I'll quote, there was a conference on psychedelic science a couple of years ago in Oakland, and Tom Insel, the former head of NIMH, gave a talk, and he's quite impressed with this research model and is actually working with one of the phase 3 companies on developing the depression study. He said to about 500 people, he said, you now, for the first time in many decades, have a great opportunity in front of you. Just don't screw it up. And I think that's kind of maybe a take-home message, that things got massively messed up in the 60s. And of course, we were in a somewhat immature culture, not prepared for psychedelics. We've now had 50 years to kind of assimilate the knowledge and to evolve, to mature, and hopefully we'll handle it in a more appropriate manner moving forward. So this is my final slide. Future challenges, and these are ancient mushroom stones from Central America used for religious purposes. They're keeping an eye on this field, so but here, what do we need to implement the lessons of the past? These include, how did the indigenous, I actually wrote a number of papers with Marlene Dobkin de Rios, an anthropologist who studied indigenous use of various plant hallucinogens, and we wrote some papers contrasting with misuse in modern culture versus how they were optimally used, and set and setting, proper intention. These are all very important things to native use. Also implement the lessons of the past vis-a-vis what was learned in the 50s and 60s. So quite a bit was learned how to optimize safety and maximize outcome. We need to, again, safety is a major priority, because if we don't establish and maintain really strong safety parameters, the field may not survive. Same thing with ethical parameters. You know, psychedelics will augment whatever's going on, and there are all sorts of ethical missteps that, you know, one can observe in various health professional fields. But when psychedelics are involved, the risks of injury are even greater. Also, prioritizing public health implications. We need to be cognizant how this rolls out to the public at large, particularly young people. We don't want this to be seen as kind of an open doorway for young people to engage in highly risky experimentation. There's also a need for more diversity in the field. If you go to these meetings, you'll see most of the presenters are older white males, with some younger white males. And there need to be more women involved in the field, including in leadership position. There need to be more people of color who are welcomed into the field. You know, the whiteness of these meetings is a little blinding sometimes. So there needs to be some attention given there in today's modern world. The regulatory obstacles are manageable. We even established that was the case back in the early 90s, when there was still a good deal more resistance. It took time. You know, I never had a protocol that they just sent back to me as approved. It came back as, well, you need to make some changes. But you know, I tried to develop, you know, kind of a collegial rapport. I listened carefully to their input, and I made the changes I felt I needed to change. Those I felt would harm the study, I kind of made an argument why we couldn't. And at the end of the day, it was all workable. And now the regulatory agencies are more positive and even enthusiastic about the potentials here. And also the funding options. Well, you know, we have an interesting situation where we have a handful of very well-funded entities pushing their own agendas. One of them is a for-profit, the other two are not-for-profits. But what I've learned with the for-profit is that a not-for-profit can overnight turn itself into a for-profit. And, you know, what's the motivation there? How might that affect establishing the strongest structures for treatment, including, let's say, what are the credentials of individuals doing this treatment? You know, do they need to be clinically trained and clinically licensed, or, you know, can anyone off the street do it? Now, that being said, there's been an underground in this area for many years, and there are certainly some highly qualified facilitators there. But I think if we're moving forward in a formal manner out in the world, there needs to be a high bar for credentials. So I think I've ended with a little time left, if anyone has comments or questions. Okay, Michael.
Very intrigued. It would be hard not to be intrigued by that book. What was it you had objections to in the book?
I just thought there was a limited focus. He would go in great detail, and it was a great read on some individuals like Paul Stamets, the famous mycologist. I think there was just more that could have been covered. He also, I felt, didn't give adequate attention to where these compounds come from. They come from the prehistoric world, the indigenous world, and I thought that needs to be credited, and there needs to be some kind of payback to the native peoples who kept these traditions and these plants alive through century after century of persecution, and this really belongs to them. There's a lot we can learn. Yes, Jim.
Has anybody learned anything about potential bad interactions with drugs that people might be taking on a daily basis before they go in and get their, you know, their ecstasy or their psilocybin?
Well, there's a paper in the Annals of Internal Medicine some years ago entitled "The Agony After Ecstasy," And it was an individual who took ecstasy or MDMA, but was also on an MAOI, antidepressant. So that's the most dramatic example. Also, I published a paper with my colleague Jace Calloway on adverse interactions between ayahuasca and long-term SSRI use, serotonin syndrome.
Hi, Dr. Grob. Thank you for a fascinating talk. My question is related to the concept of set and setting and how it interacts with the actual compound. Specifically, this idea of safety versus efficacy. So, at the ASCP conference, the FDA talked about how they're not in the role of regulating psychotherapy. However, they can mandate parameters to ensure safety through like a REMS program, for example. So I guess my question to you is, in your experience and from what you've seen, how certainly the quality of the psychotherapy component, the preparatory phase, the kind of intra-session guiding is essential to maximizing efficacy. But what about ensuring safety? So maybe to Jim's question, what's the interaction between a low quality psychotherapy and psilocybin inducing a bad experience? And I guess this relates to if it's really truly a safety question. And it makes it into like the REMS arm, for example. Do you just require, 2 guides being there versus 2 guides with extensive training and credentialing kind of in this area?
Yeah, the guides or the facilitators or the therapists would need to be trained. And there are training programs now that are being developed, one in the San Francisco Graduate School, the California Institute for Integral Studies, and another by MAPS. So, and also, look, even with all the credentials in the world, some people are just not good therapists, and they wouldn't be appropriate. And somehow or other, a process needs to be established to weed such people out. I could tell you a story of it in the early days of psychedelic research. A doctor and nurse were treating people, and for whatever the reason, they got into a very nasty feud. And they didn't talk about it in the treatment room, but from what I was led to understand, the tension level was quite high, and the patient had a significant meltdown that was later attributed to a problem between the therapists. People have, in addition to good credentials, they need to have their act together, and there needs to be good rapport between the 2 facilitators. Now, one issue that came up at the recent meeting was, maybe 1 therapist is enough. Well, maybe, but then maybe not, because these are long days. They're like 6 hours, 7 hours, you're in there. I assume that therapist might need to go to the bathroom at some point. Who's there with the patient? And you never, ever leave somebody unaccompanied, unmonitored during these experiences.
So just actually following that a little bit, you mentioned that you felt it was most effective to have a team of 2, of a male and a female
Right.
therapist. Why is that? I'm curious.
Well, for starters, maybe as a safeguard for inappropriate boundary dissolving on the part of the therapist. And although it could happen with a male or a female, it's statistically more likely to be a male, and having the female co-therapist in the room could be a bit of a check there. And then you never know what kind of issues may come up where a male presence is needed versus a female presence. With the MDMA study, there are a couple of the guys we work with who really needed to engage with me and have extensive discussion about various things going on in their life. With the psilocybin study, where people go deeper and are more prone to maybe getting some anxiety, on a couple of occasions, I could sense that our woman subject was getting a bit anxious, and I felt she needed some touch, but I felt if it was me, it could set her off. So I instructed my co-therapist, Alicia Danforth, to sit with her on the edge of the bed, hold her hand, reassure her, and the subject calmed down right away, and I felt that was the right call there.
Thank you.
Thanks. On the safety question, I wonder if you could address where things are at in the field with screening people for potential serious adverse reactions, like predisposition to psychosis or?
Right, yeah.
that kind of
So anyone with a psychotic episode is screened out, and some of the studies are also screening out people with a first-degree biological family relative with a bipolar disorder or a thought disorder. Also, a history of bipolar with the subject would be a screen out. Yeah, you know, and I've been questioned about this, but I feel with these early studies, you have to err on the side of caution. Yeah.
Do you think we'll get to a point of sort of like personalized medicine, sort of genetic markers for?
Oh, that might be the case, sure. Sure, absolutely.
And that's all the time we have for questions for this morning, but if you have questions, feel free to come up and talk with Dr. Grob. Thank you again.
Okay, sure, thank you.